trickle in. There we go. So we'll just give a couple minutes for attendees to join here, and then we'll kick things off. Perfect. The room is filling up.
I thought I'd maybe show one picture. Connor?
We love pictures.
You love pictures. Well, good.
I think that's a great idea.
Share, or are you going to can you share as a presenter? Connor, can he share as a presenter?
Yes, let me make sure that that we have those permissions set correctly. Okay. Great. Okay, 6:05. Got a decent number of attendees here, so we'll go ahead and get things kicked off. So thank you to everyone for joining. My name is Connor Handy. I'm a friend of the Schenkel Clinic, and I'll be facilitating this evening's presentation as well as the Q&A that will follow. Just to start a few quick notes. Our session will start with a presentation and conversation between Dr. Schenkel and Dr. Mahakian, who's joining us tonight. And then, as I mentioned, we'll open things up to Q&A. If you have questions that you'd like either of our hosts to answer, use the Q&A function within Zoom at the bottom. You should see a button that you can click on and type a question that will come to me, and then I'll bring those up with each of our panelists here. We may not get to all of them, but I'll make a point to copy them down, and we're going to try to address them afterwards in some format, the questions that we don't get to. As you may know, video and audio are disabled for the attendees, so we cannot hear you, just so you know. And lastly, we're going to post a recording of the webinar on YouTube and on the Schenkel Clinic's website, maybe other places as well, in the coming weeks. So stay tuned for that, and that link will be available to you all if you'd like to pass it along for people who weren't able to join tonight. So those are the housekeeping items, and I'll start things off with a brief introduction of our hosts. So first, Dr. William Schenkel. Dr. Schenkel is one of the country's leading experts in Alzheimer's and other age-related neurodegenerative conditions. He spent over 3 decades treating patients fighting these diseases, conducting research to advance our knowledge of the brain, and developing new treatments to delay or prevent the progression of cognitive impairment. In 1997, Dr. Schenkel founded the Schenkel Clinic, a neurology practice headquartered in Newport Beach, California, focused on the management and treatment of neurodegenerative conditions. Prior to founding the Schenkel Clinic, Dr. Schenkel served as the clinical director for the Alzheimer's Research Center at UC Irvine, which he co-founded. He also served as the director of Memory and Cognitive Disorders program at Hoag Neurosciences Institute. Currently, in addition to leading the Schenkel Clinic, Dr. Schenkel serves as the chief medical officer for MBIC Corporation. He's a research associate with Hoag Memorial Hospital, and he's a clinical PI for a 5-year NIH grant with UCI. So that's Dr. Schenkel, and our co-host tonight is Dr. Jane Mahakian, who we're excited to have with us. Dr. Mahakian is a gerontologist and author. Prior to founding Aging Matters, Inc. in 1998, she served as an adjunct faculty member at the University of California, San Francisco Institute on Aging. There, she developed the university's elder care referral program. Dr. Jane received her clinical training at the Veterans Administration Medical Center in San Francisco. She specializes in helping adults and their families with cognitive impairment and has expertise in working with people with behavioral challenges. She helps families develop a plan of care and provides transitional guidance for their loved one with dementia. Dr. Jane is the founder of Alzheimer's Care Armenia, a nonprofit organization that develops sustainable programs and services for people with Alzheimer's disease in Armenia. In 2023, Dr. Mahakian developed Armenia's National Dementia Plan in cooperation with the Ministry of Health. She oversees a multidisciplinary healthcare team that provides countrywide early detection memory screening, as well as home-based cognitive and healthcare services to people with Alzheimer's and their families. Dr. Jane created several memory cafes in Armenia this past year and is developing a geriatric model of care for primary care physicians that their government will incorporate into their medical system here in 2024. So exciting stuff at home and abroad. So without further ado, I will turn things over to Dr. Mahakian and Dr. Schenkel for their presentation tonight titled Managing Challenging Behaviors in Dementia. So to you, Dr. Mahakian.
Thank you so much, Connor, and thank you so much, Dr. Schenkel, for inviting me here this evening to talk a little bit with you about managing challenging behaviors. I'll just begin briefly and talk a little bit about quite often when I meet with families, spouses, as well as children, you know, they want to really kind of understand, how does the disease, you know, how does the cognitive impairment affect their loved one? And I have to say, one of the most important points to really remember is and to think about is, many times the person with a dementia is really unaware of their limitations. They may not be aware quite often of their diagnosis, and reminding them of these limitations really isn't what you want to do, right? You really want to make your person, your loved one, feel useful, engaged, and in control. What makes the disease challenging is it's unpredictable and inconsistent, and it can change quite often. Many times the person will not self-initiate. They may make up stories, and the stories serve a purpose. The stories many times are a way of, what I have found, either making peace with something or a way of kind of fighting against fear. So your job, or task, shall we say, is to really affirm that positive thought or delusion, and kind of move the, shall we say, the person from any kind of negative or scary delusion. And I'll share a quick story with you. Was a dear patient of mine who had a belief that the president and Mrs. Bush were visiting Philadelphia and they needed a room to stay for the night. So she offered her home and they spent the night. And this client believed that you know, the president and the first lady spent the evening. And the daughter decided to affirm that and said, well, that's just really fantastic. How nice that you had the president, you know, and the first lady be with you. So I think that's important to really kind of understand that the people with a cognitive issue impairment are not going to do something intentional. They're not doing it to get to do something on purpose like that. You know, the behavioral problems that do occur, the behavioral problems, why they occur, you know, usually I have found that there's really three general reasons why they happen. One is either emotional or mental. The other one can be environmental, the setting, the home, where they are, a change of environment, or it could be something physical, as in experiencing pain. as the disease progresses, you really want to be watchful of any changes that are out of the norm, and really kind of determine what he or she is trying to tell you non-verbally. I've seen, you know, because they're not intentional, you know, you have to kind of be a detective. I was speaking with Dr. Schenkel about this a week ago, about how when communication diminishes, those behaviors really become part of that person's language.
Yeah. You know, I often get asked to treat a particular problem and say, give me a pill. And so the first thing, as Jay mentioned, is do they have something that has triggered the behavior? Did they get a visit from a relative that they haven't seen for a while, and it kind of brought up some things? Were they traveling recently? Have they not been sleeping well? Have they gotten out of a routine in some way? Have they had a recent change in a medical condition? Frequently, you'll see changes with urinary tract infections, falls, and all of these things add up together to produce the behavior. And frequently what we see is an exaggeration of an underlying personality. It just becomes very extreme. So the approach that I like to take is first to exclude some contribution from a medical problem, infection, a medical condition that's not well controlled. Secondly, to explore what are the driving forces to the behavior. Is it typically when a caregiver tries to help them change their, change their clothing or take a bath? Is it when their head gets wet in the shower? They get upset about that. And so, number one, rule out medical. Number two, identify the triggering behaviors. And number three, I guess this goes along with the triggering behaviors, is there's really a big effect of inconsistency in the daily routine. The patients that have a regular daily routine, what they're doing is they're compensating for a memory problem. If you don't have a memory problem and your day, you just kind of decide what you're going to do and it's fine. But if you've got a memory problem, trying to think up what to do is hard. And so a lot of times what ends up is people just sit there, do nothing. And boy, when that happens, what does the brain do? It starts generating stuff. The Martians are coming. My most hated relative is outside knocking on my door, all sorts of bad stuff. And so it's that irregularity of a daily routine is often the reason for a behavioral problem. And that gets made even worse by the universal fact that once there's a significant memory problem, universally, people can't start things on their own. They can do them. Most of the things they can do. They just can't turn the engine on. And if no one turns the engine on, that's when all hell breaks loose in terms of behavioral problems. So, that's why I try to get people to find a solution to set up a regular daily routine. And I refer often to Jane Now that, we have a publication in Journal of Alzheimer's Disease that showed that compliance with the right daily lifestyle has a huge effect on the progression of cognitive impairment and dementia, much bigger than the newly approved drug for Alzheimer's disease. These things are really effective, and they also provide a better quality of life. So, you've got behavioral problems are all over the map. Some people withdraw, some people get angry, some people get agitated, some people cry. It's all over the place. And so if we can kind of identify how to, and maybe Jane can talk a little bit about how do you set up a regular routine, especially in people who haven't usually had one. What do you think?
Yeah. Absolutely, Dr. Schenkel. It's so important to really provide that and develop a routine at home so your person can be successful. And just like, all of us before as I tell many of my patients, before, their feet hit the floor, right? In the morning, before you get up, you need to know what you're doing today. And as Dr. Schenkel was saying, maybe we can decide that, well, we're not going to do that today, we'll do something else. But your person that has a cognitive impairment isn't usually going to do that. So that's in part why some of the behavioral challenges come up, is because they're not able to express their feelings and thoughts, or they're bored at home. Some of the, many times, it's quite often that there's nothing to do at home, or because there's a lack of structure and a lack of a schedule. And sometimes kids will say, well, my mom is not going to go for a schedule, Dr. Jane. She just won't go for it. And surprisingly, they do, because there's a sense of safety and security and predictability in knowing what I'm going to do today. So focusing on what that person can do rather than what they cannot is what you want to do. And when I meet with folks, designing a daily routine, that schedule conveys a sense of purpose for that person, as well as routine and structure. They're not going to self-initiate, like Dr. Schenkel had mentioned. And also having like a whiteboard is important in the home, to have the daily routine on a whiteboard, but also to have it on a piece of paper that you can review over breakfast, and they can keep that paper with them. It really provides a sense of self-efficacy. It really does. And it also kind of helps bridge a lot of the issues with isolation. So as the person that has more social ability and is more engaged is going to do better cognitively. So developing that daily schedule with a wake-up time, including breakfast, you can review, or the care provider can review the daily schedule with him or her, and giving them tasks to do around the home. I remember, maybe several years ago, there was a gentleman whose wife had moderate stage Alzheimer's disease. And every day one of her jobs was to do the laundry, was to fold the laundry. Now, of course, he wasn't running the wash machine every day, but would simply take towels and linens out of the linen closet and put them in the hamper, and then present them to her as something that she could fold. So giving her a sense of helping out around the home and helping him really brightened her mood, and it really helped. He also had her sort the mail, go through the mail, those pieces of mail that were not, you know, significant if they got lost. He also had her go through like a grocery list or grocery store flyers and circle the items that she liked and would like to purchase. Sometimes patients will do really well at home, but depending upon, of course, who they are. So bringing in their past, things like building models. I recall recently a patient who loves to do woodworking. And so now he's doing models at home that he snaps together, and he's really enjoying that. So figuring things out, kind of thinking out of the box a little bit, maybe emptying the dishwasher, and it's perfectly okay if, you know, things get a little bit mixed up. You can always correct it a little later, but they feel that makes them feel good. And that's what you want to do, is you really want to build on their sense of self. Same thing with exercise. You know, you can build in a schedule every day with some kind of exercise. You can also have physical therapy at home, right? You can have, you know, to work on balance or work on gait. I have one of my patients who's living in a memory care community goes swimming 3 times a week. It's important because he was a lifeguard, and we want to keep that part of him. You know, he loves that. So there's a lot of things that you can do at home. There's a lot of ways to create that daily purpose and life meaning. There's also day programs in Orange County. There's many day programs. There's classes and other types of even volunteer opportunities if the person can do that.
You know, Jane, there's a colleague of mine named Barry Reesberg, and he did a lot of work on the functional abilities of people at all the way from normal aging to very severe stages of dementia. And what he learned was he published this, and it was called The Theory of Retrogenesis. And basically what he found was that according to the stage of functional capacity on his scale, which is the FAST staging tool, stands for Functional Assessment Staging Test Procedure, which I have used for more than 20 years now, you can actually know what mental age the person is at. So, for example, a person who's having difficulty putting on their own clothes, their mental age is approximately 4 years old. And that can end up being useful because once you kind of have knowledge about what age their brain is working at, okay, then you can select things that are doable for them. And everybody likes being able to do something. You know, we don't try to do things we can't do. We do things we can do. That's why some people play, you know, rummy cube all day long, if that's the only thing they can do, and doesn't necessarily bore them. They probably like it. You know, so I've really learned that if you know the person's past interests, then you could take that knowledge along with the knowledge of what mental age they're at. You can pick a similar interest, but at a simpler level. And I think people often find that it works pretty well. Yeah.
Yeah, absolutely. Absolutely. That is so important. Very important to know that person's history and what's important to them. It's very important. And it's also important, you know, if your loved one transitions to assisted living or memory care community. So it's important that the community understands your loved one and understands the history and is knowledgeable about his or her likes and the things that gave them passion in their life, because those things in a good community will be kept alive, and that's really a key. You really want to do that. I think you know, it's very important. If I could maybe share this story, and how what happens with some of the challenging behavior was, we'll call him George, was living in a memory care community and fairly new. He had been there about 3 or 4 weeks. And I happened to be at this community and walking to meet a client of mine. And then I began to hear some pounding going on pounding on a table on the during lunch, and asked, you know, what's going on? And the staff said that, well, every mealtime, George pounds on the table and they really can't figure it out. They don't understand what's wrong. And the administrator happened to be passing by and said, yeah, you know, it's so disruptive. We really don't know what to do. And, you know, there was definitely something to remember for all of us as earlier, you know, talking about this is the big issue is really uncovering that driving force behind the behavior. What is this? What is this about? Because it's not intentional. There's a purpose to this pounding on the table. So I asked the administrator, you know, I'm happy to help in any way I can, you know, tell me more about George. And she said, well, we, you know, don't know too much, you know. I said, well, why don't we get the kids on the phone call and let's have a conversation. So we did, and it turned out that this gentleman was a judge, that his profession was a judge, Dr. Schenkel, and he was pounding on the table because he needed to have order. So, oh boy. So that was an important piece of information that the caregivers didn't know, the staff, you know, nobody knew. And so what are we going to do? Well, you know, they had him, George was reassigned to a different area of the memory care, different dining area with less people, and it was less chaotic. And he did just great. The pounding stopped. So he was trying to tell everybody that he needed order, and nobody was listening to him. And they were close to saying to the family, you know, we can't handle your dad, you know, oh my goodness, you know, that's really not good. The other, I could share this. Shall I share this story, Dr. Schenkel, about Caroline?
Sure.
This is an interesting story. Caroline, and again, you know, how do you know, you can't reason with someone when they have, you know, moderate dementia. You can't reason, because if you reason or if you argue, you're going to lose, and you certainly don't want to argue with your loved one. You don't. So every day, and this is a true story, and Caroline, not her real name, of course, was living in a memory care community, and she became very anxious every day around 4 o'clock, just like clockwork. And she began pacing and knocking on the door and wanting her parents to come and pick her up. She began to yell. She was tearful at times. The staff tried to redirect her, and she would push them away, and it did not work. So what to do with the staff? You know, they needed some other type of intervention because it wasn't working with Caroline, and she wanted her parents to pick her up, and Caroline was 86 years old. but she believed her parents were still here. So the intervention went like this, which was a brilliant intervention. And Caroline was told that she had a phone call. And the phone call at the other end of the phone was the nurse from the facility on the other line. And the nurse said, this is the Hyatt, I'll never forget it because I was there. This is the Hyatt Hotel calling. And we want to let you know, Caroline, that your parents are running late and they'll pick you up tomorrow. Well, we all know that wasn't true. It was what we call a kind of lie or a therapeutic fib. But Caroline's reality was validated. And her reality that her parents were going to pick her up made her feel safe. And they continued to do this day after day, that your parents, are going to come tomorrow, they're running late. While I'm listening to this whole intervention, transpire, Caroline hangs up the phone and turns and says, my parents, and had some very colorful words for her parents. And she said, they're always late. They're always late. And the staff then said, oh, Caroline, can you please help us set the table? And that was it. So it affirmed her reality, and it made her feel really good about that her parents were coming the next day. Now that's really an important intervention. I'm not suggesting that, we begin to not telling the truth. However, there are times during the process of, during the journey of this disease that we can't always be truthful. We cannot always be truthful. And I think it depends upon what it is, right? Really what it is that we're talking about here.
Yeah. There's something called, it's a neurological condition when certain portion of the frontal lobe is affected, and it's a portion of the brain that is a self-monitoring system, and it monitors your own behavior. And so that particular system is the third area of the brain where the tangles of Alzheimer's form. And when it reaches there, the person loses the awareness that they have a memory problem. And almost every day I will get a family that will try to convince their loved one that they have a memory problem, and that's why they're here to see me. And the person just simply isn't aware. It's not denial. That's something that got promoted, particularly by the Alzheimer's Association. And I never understood that, because you can't deny something you're not aware of. It's loss of awareness. So using the reasoning like, well, remember you you forgot to come to the doctor's appointment and you asked me 15 times today that you were coming? Yeah. And no, that's not me. I know who you're talking about. So it's like, it's pointless, and it's also irritating people. The people with the dementia, it's irritating to them to be told they're impaired. So there's just no point. And you go with the flow on these people. You always go with the flow. I do this with my mother every night. Every night her parents are coming over, just like Jane's friend. And, I say, well, shall I give them a call? Because they're like over in New Jersey and work in California, and it's about 2 in the morning.
Mm.
Oh, no, don't bother them right now. We'll talk to them tomorrow. Okay, yeah, no problem. And so big lessons. Learn where that person is. I think it's fun, actually.
Mhm.
Fun
Yeah.
to kind of get into their brain and where
Yeah.
they're at. Okay.
Well,
Second, yeah.
you're may I just had like this thought, of this story, and it's all, it's they're all true stories, but many years ago, Dr. Schenkel, I took my grandmother, who was at that time 89 years old, from Turkey to Las Vegas.
Oh.
And she had dementia.
Mm-hmm.
She had a vascular type dementia. And it was just the two of us. We went to Las Vegas. The minute we went to the casino, she wanted to play the slot machines. And she played and played until she ran out of money. Then she turned to me and said, "Let's eat lunch." We had a delightful buffet lunch. She ate an amazing, she was very petite, but could eat, just lots of food, enjoyed herself. And then she turned to me and said, "I want to go play that machine again that I played. I want to go back to that machine and I'm going to go play it again." And I said, "Okay." Went to the ATM. She drew more money out, and we're walking around trying to find that machine. And I said, "It's this way. It's 2 rows down that way." She said, "No, it's not, honey. It's this way." And I said, "No, it's not." And this was a long time ago. This was before graduate school that I took my grandma to, to the Vegas. "No, honey, it's not there. It's this way." I said, "Okay." And I'm thinking she's wrong. She sat down, started playing the machine. And at that time, when you dropped in, you could drop in your money, you could hear it go down. She's playing and playing, and 20 minutes into it, she hits the jackpot. And she won $2,500. She turns to me and she said, "Honey, I know you're becoming a doctor, but I want you to know one thing." And this shaped my entire career. She said, "People with memory loss like me are always right. We're always right." And I said, "Grandma, okay, I understand, I get it. You're right." And I began to think of this concept, right? We
Mm-hmm.
go to the airport, it's now time to leave 4 or 5 hours later, or the next day. She turns to me and says, "Where were we? Where did we go?" "Well, we were in Las Vegas and you won a lot of money." The point is that she needed to feel she was right. Even though she wasn't right, it's my being able to jump into her shoes and be in her reality. And as long as it's safe, it's a safety, that delusion or misinterpretation or her reality of how she experiences something, as long as she's safe, I'm going to go and roll with it. So case in point is a delightful patient who I've been now seeing this person at least 11 and a half years every week.
Hmm.
And she believes that she owns the memory care community she's in. She believes that. And she even has a name badge. So she's validated. That's so important. And, I remember too, the recent patient living at home who is doing really well on her schedule, and so well that she can't wait till the next day to see what's on her schedule. So in some of the things she may make up, like she said, "Well, I had my girlfriends over for lunch. There were 8 of them." And I'm thinking, wow, that's incredible. The caregiver made lunch for 8 of your friends. That's fantastic. when I checked in with the caregiver, she said, no, it wasn't 8, but a friend did come over, and that's really nice too. But these are the kind of stories that you want to just make them validated and real, because it makes that person feel good.
All right. Well, what can you say? It's a crazy world. It can be fun sometimes, you play with it. And the other thing I just want to mention is that when people get irritated and agitated, that's not abnormal. That's normal. I mean, if I'm losing my memory and I'm aware of it, or even if I'm not aware of it, I'm getting pretty scared. And then I might blow up at nothing, but all of that was building up, and it's scary. And, it's kind of okay to say, it's okay. I mean, I'd be pissed off too if I was losing my memory. It's the way it is. I mean, and people, I look at people when I tell the families that and the patients there, I said, it's normal to get upset. It's normal to get irritated. I would be, I am. Okay. So, let it go. I mean, there's a lot of things you can let go.
Yeah.
Well, I
No,
guess really quickly on that point, I think this comment comes from an attendee. I'm assuming that they're a caretaker, and they're saying from their perspective, it's frustrating and exhausting to always have to be the one to take the blame. So I don't know if either of you have any advice on, other than, just trying to show as much compassion as possible.
Yeah. Yeah. Shall I go first, Dr. Schenkel, or would you like to?
Please do.
Take the blame, right? It's really a way to diffuse anxiety, agitation, sometimes even aggression when you apologize for something that is not, you're taking the blame, you're owning it. We all have to do that when we have a loved one that has a cognitive impairment, because it makes them feel better. And as Dr. Schenkel had said earlier tonight, you have to roll. You have to be very flexible. And part of the treatment, it's not beyond pharmacological intervention. Part of the treatment is learning and communicating with your loved one in a different way, in a way that makes them feel good about them and doesn't remind them that they have a cognitive impairment, because you really want to focus on what they can do. You want to focus on what they're good at and what they can do, and making them feel, there's hope. We all need to have that hope, and it's very important that they feel that there's a purpose, and there is a purpose.
There's a great book, Jane. I can't remember the name of it, but it's about how to communicate. You know which one that is?
Yeah. I did. That's funny, Dr. Schenkel. Oh, the I Hear You book by Alison Kuhn, my co-author, and myself. And we finished that book, Dr. Schenkel, during the COVID pandemic. My co-author, Alison Kuhn's mother, was a dear patient of mine up in San Francisco. And she went through, it was a real journey, as it is for all of us to have a loved one, spouse, parent, grandparent, aunt, uncle with a cognitive impairment. It's different for each of us. The disease is just, it affects everybody a little bit differently. But thank you, Dr. Schenkel. the I Hear You book, and you know, there's lots of good things in there about communication. And I think, it's important to step into their shoes, and that's where you have to be, because they don't want it. No one wants to be reminded that they have something wrong with them.
Yeah, you learn their language. You learn their language,
Mm.
and it makes it much
Mm.
easier.
Mm-hmm.
In fact,
True.
when just to respond to the person who gets tired of taking the blame, I'll just tell you a little story. There was a study many years ago by the LA Times, and it was about what constitutes a successful marriage so people don't end up getting divorced.
Oh.
And they did all sorts of, research and about styles of communication, couples counseling. And what they finally learned was the marriages that don't end up in divorce are where the husband does exactly what the wife tells him to do. And
Ah.
I've learned that, and I'm happy to take the blame all the time. It's my fault. You're right. You are so right. I screwed up again, didn't I? And boy, does that work. Yeah.
So you're right, Dr. Schenkel. What happens is it diffuses a lot of the angst, the agitation. It diffuses it, and it distracts. You can also, using distraction too, with bringing in something completely different. I mean, I have found that what really helps is saying, "Can you help me with this?" If somebody is upset or agitated or more confused, I may ask them to help me with this, or I may show them photo albums. So going through and reminiscing, who are these people, even if they can't remember and they make it up, that's perfectly fine too. But it becomes more concrete for them, and it helps provide a distraction for them. So photo albums, picture books, they're all really good tools to use. You have to have tools to use, to pull out.
That can be particularly useful when the affected person was a person of power and in charge, and they're losing it and they're scared. And that comes out as anger and aggression. And if you could bite the bullet and swallow the pride and just, oh my God, honey, you're so right. I mean, what didn't I think of that? It can really diffuse a lot.
Yeah, absolutely, Dr. Schenkel. Underneath a lot of that anger is a lot of fear.
Yeah.
And fear of there's of awareness at times, and fear of where they are. They may feel confused, they don't know where they are, or something's changed. So sometimes the aggression is because of fearfulness.
If you don't know how to process something, you don't know what's going on, that's pretty scary.
Yeah. Yeah.
So just want to start, we are getting some more questions trickling in here. So I'm just going to rattle off a few of these. The next one, we have a question about someone with a loved one who previously lived on their own with in-home care. And this caregiver feels that it's about time for them to start transitioning to a memory care facility, and mentions that they're about an 8-year-old level of cognition, but cognizant enough to know that what that type of facility is, and that they know they don't want to be there. They don't want to be put into that type of facility. So how do you kind of manage that transition with them, and perhaps convince them that that is would be a better place for them to be?
Well, I'll make a brief comment, but I'm sure Jane's had to deal with this so many times. First of all, they don't have any idea what it's like because they've never been there. So that isn't even logical, okay?
Mhm.
Secondly, it's the fear of the unknown. So one thing is some of these places will provide what's called respite care, where they can go over there and hang out for a while. And, you know, it's like putting your toe in the water and getting a little bit more familiar, maybe meeting somebody. And some of them even have where you can spend a weekend there. You know, it's just not such a black-white transition, but kind of a gradual transition. Makes it a hell of a lot easier. Jane?
Yeah, yeah. No, you're absolutely right. You know, I think it really, everybody's different. So, you know, and I have helped countless people, families, with the transition of staying at home with home care. And how do you make that transition to bring in good caregivers to your loved one's home? Because that's a huge transition. Also, transition to small homes, little board and care homes, or assisted living communities, or memory care communities. For everybody, it's different. And, you know, I look at the person's history and who they are, and then develop. So I can't, there's not a general statement or a general way to do this. It's really very personalized. So what works for one person will not work for another person. Um, I, I think that, you know, trying out, some communities will allow that, is an idea. But again, it's all in how it's communicated and what the approach is. It must be kept very, very positive. And they must feel that they're gaining something by that transition. Just like last week, a patient, Dr. Schenkel, and this patient needed home care and did not want anyone in her home, nobody. And so the family brought me on the team to figure out how can I get this caregiver that they chose and they liked to be their mom's caregiver. Well, it wasn't easy, but you have to kind of think out of the box. And for that person, for that patient, it was presenting her as a chef. And she wasn't there to care for her mom or care for herself. She was there to cook.
Jane, I'd like a chauffeur. I hate driving.
Well, that is also another idea too. That is also another idea, is to have a chauffeur. So it's, again, it's how it's presented. I mean, I've gone so far as to have, you know, the caregiver, this is maybe a year or two ago, and I think it was actually one of your patient families that I spoke with, and the person dressed up in a black suit. It was a caregiver, and he was the driver for this couple. And both of them had, you know, advanced dementia, but they didn't want anyone in their home, but the driver was acceptable.
Yep. Yep.
So he wore a black suit every day. And then eventually, you know, as the bond, as they formed the relationship, you know, he was helping with showers for the gentleman.
Mentioned just before we have to leave. Jane and I have been talking about kind of interesting things that might be helpful, that would be easy for families to do. And so I don't know, Jay, if you wanted to mention a little bit about some of the things we're thinking about that we might be of interest to people.
No, yeah, I'd love to hear your patient family feedback. Absolutely. We were thinking about several different support ideas, support services and program, um, such as like an educational support class that would be at the Schenkel Clinic to talk about these issues, the behavioral challenges, how to develop a plan of care for your loved one, both today and also in the future, because you don't want to be crisis driven. You want to have that plan of care now for the future. As well as perhaps a support cafe, like I have several of them in Armenia right now that are very successful for people with mild cognitive impairment, which is amazing. Doing a lot of memory enhancement type activities and reminiscence, which is really important. I think a big piece, a lot of the work I do out here, here in Orange County is really in care development, care planning. How do you select a great caregiver? What do you look for? What are the things that make that caregiver great?
Exactly. Yeah.
It's not about, it's really about not only how well trained they are, but how trainable are they? So these are the kind of things that, we're in conversations with the Schenkel Clinic team and developing other programs that I think are going to be more, they're going to be supportive.
Yeah, I think the idea, I mean, a lot of times you get caregivers and they want to help, but maybe they just don't have the training yet. And maybe what we need to do is figure out a way to provide some on an individual basis or
Oh yeah,
tailored to the family, to the
it's a
patient.
great idea. It's a great idea.
Yeah.
Because we certainly know that the caregiver agencies are not providing they're I've seen very few caregiver agencies providing that kind of level of training.
No.
And that's really needed. We all need tune-ups in our training, right? And I think it's important, but I think all of these ideas are really what people need.
Yeah, it took me years of training to learn to be a husband.
Well, that's funny.
There's some transferable skills there, right?
I'm still learning.
Yeah, you're good at taking the blame. That's one skill that's transferable for caregivers and spouses.
That's funny, Connor.
Well, we are at 7:02. I want to be conscious of Dr. Schenkel and Dr. Mahakian's time tonight, as well as those who have joined us. Thank you of course, to both of you for leading this great discussion. Lots of fantastic information, and I hope that we did get to a few questions. I know that there's some more in the channel here, so we'll try and follow up with some responses to those. And as mentioned, this will be posted online later. So for anyone who didn't have a chance to attend tonight, there will be a link that they can view this on YouTube. If you didn't notice, I did include a link to Dr. Mahakian's book in the chat for anyone that wants to access that and purchase that resource. And thank you to everyone for joining tonight. It's been a great conversation. We're happy to have all of the participants here. So any closing thoughts from Dr. Mahakian or Dr. Schenkel?
Thank you so much. Thank you so much, Dr. Schenkel and Connor and the Schenkel team for inviting me this evening. If I can help in any way with any of the responses, I'm happy to do that. I don't know how, if you'd like me to do that, I'm happy to do that. And I think, I think my closing remark really is all about, making you know, your person, elevating your person and making them feel, you know, very effective in their life and purpose driven, really. That's what it's all about.
Yeah, I think I just thank Jane. I've worked with her for almost 30 years now, and I have seen her work miracles. So I'm very delighted that we could have you today, and I'm looking forward to developing better programs with you.
Thank you, Dr. Schenkel. Thank you very much. And I look forward to working with you and the Schenkel, your Schenkel team, Schenkel Clinic team.
Right.
Thank you.
And for those of you still on, the viewers, stay tuned for those resources and any developments to come. There will be in newsletters and on the Schenkel Clinic website, etc. So more to come on that. We look forward to it. Thank you both, and have a great
Thank
night.
you. Have a good evening.
Okay.
Thank you very much.
Bye bye.
Bye-bye.